So I think you'll see my last talk, cardiology is definitely my comfort zone. Hematology is not. So nonetheless, I hope I can hopefully impart in you some of the wisdom that I've accumulated over the last 30 years or so about the bleeding disorder that occurs in Jacobson syndrome. I'm actually surprised that there's still, or maybe shouldn't be surprised, a lot of confusion. So I'm going to try to simplify it for you. I would like to preface this by saying that for those of you that were at the Washington, D.C. conference 4 years ago, Dr. Lambert from CHOP, Children's Hospital of Philadelphia, some of you have actually seen her for your child, gave a great presentation. And I actually went back and watched her presentation to make sure I wasn't saying anything out of line for today's presentation. I believe she has graciously continued to offer her time and expertise to any of the Jacobson syndrome families. And again, even if possible, I would encourage you to pay her a face-to-face visit. So take advantage of that. She is a great resource. So I've kind of entitled this "What You Need to Know," so a little bit more of a practical hands-on. We do have a bleeding protocol that I'm sure most of you are familiar with. It does need some updating, and there are some nuances and details that I think really only a pediatric hematologist has the knowledge to do. And we're hoping maybe Lindsay, you can talk again to Dr. Lambert to see if she can update that for us. I will say this, that wherever you go for your child's needs, any major children's hospital not only will have a hematology department, but they should have a pediatric hematologist that specializes in platelet disorders. That's who you want to go see. And any pediatric hematologist that specializes in platelet disorders should know about Trousseau. If they don't, then you should move on to someone else. That would be my advice. All right, and again, feel free to stop. I know we're probably running a little bit behind.
A little time.
But actually what I'm going to present is going to probably be pretty quick, which should leave some time open for questions. Okay, so what you need to know. Just to start, you may wonder where does the name Trousseau comes from? Well, Paris. Some of you may remember Remy Favier, who continues to do work on Trousseau syndrome. So Trousseau is the name of the hospital in Paris where he works. And Remy has been one of the pioneers in understanding the pathology of the bleeding disorder, the platelet disorder. So he is still, as far as I know, working, and someone told me they recently had an email exchange with him. So he is another great resource who would be more than happy to answer your questions. He is the guy. Okay, so a lot of this I'm just going to turn around and kind of read to you, but if there's nothing else you get out of this talk, and Virgil kind of laid the foundation yesterday. So Trousseau is defined by having two components. One is a defect in platelet production. So typically your child may be born, a normal platelet count is from about 150,000 to 450,000. And typically children that are born with Jacobson syndrome have much lower platelet counts, although it can be very variable. Sometimes as low as like 10 or 20,000, and that clearly can put them at risk for having early bleeding problems shortly after birth. That's why we recommend actually a C-section for anyone who's diagnosed prenatally to minimize the trauma to the head through a vaginal delivery. And there are a few case reports of an intracranial hemorrhage occurring because of the traumatic birth. And exacerbating that is babies with Jacobson syndrome tend to have large heads, so you can see how that's kind of the setup. Now, typically, but not always, the platelet count will improve over time to maybe even normal levels. However, it can also decrease, like at times of infections. The other thing to keep in mind, and again, if there's nothing else you take out of this talk, is to realize that the other component is platelet dysfunction. And platelet dysfunction, as far as we know, is persistent. And why that is so important, and I wouldn't have known this either if I weren't in the field, that a lot of clinicians, I hear this story repeatedly, which frustrates me to no end. And this is why you guys, as parents, have to advocate. Specifically for the fact that even with a normal platelet count, because the platelet dysfunction is persistent, Once your child is born with Jacobson syndrome, by definition, they have Trousseau, and by definition, they are at some risk, some increased risk. Now, what adds to the confusion is, well, and I'll get into this in a minute, that your child might seem to be fine with a normal platelet count, and then the treating physician will say, oh, your child's fine, is not at any risk. Well, there may be some, but in many cases, it may not manifest itself until specific times of risk. So you guys, with that medical protocol, even though it's a little bit obsolete, still has enough of the critical components, you have to advocate for your child. And you have to basically teach your doctors, God forbid, should they be offended, that a layperson might know more than they do in some cases, to make sure that those risks are being addressed. Make sense? Yeah? Okay, so genetically, I think Teresa and Virgil have touched upon this a little bit. There's one main gene, the gene that you heard me talk about before, fly-1, that historically is the major cause of Trousseau. So basically, when your kid has a deletion in 11q, by definition, almost without exception, that means that fly-1 is deleted, and that by definition, your child has Trousseau, period, end of story. And don't let anybody, unless they have a genetic report that says otherwise, try to tell you otherwise. That is so important. And I can tell you, I was actually an expert witness in a lawsuit many, many years ago, just as a little anecdotal story. A child with Jacobson syndrome had just had orthopedic surgery a couple weeks prior, had a bleeding ulcer. The mom was an ICU nurse, knew all about bleeding problems and stress ulcers, took the kid to the ER, their local ER, had a bleeding ulcer and was hemorrhaging. And basically that physician blew the mom off, ignored her appeals and pleas to treat because of bleeding disorder, and that child died. Thank God that was 20 years ago. I haven't heard about anything happening like that since. But again, you really have to advocate, and that's why that protocol is so important. It is a medical legal document. And if they are dismissive of that, they are putting themselves at risk for malpractice. All right, I kind of touched this already. Your child has Jacobson syndrome, they have Trousseau. Again, what adds to the confusion is the clinical presentation can be variable and it can change over time. And in my opinion, just like what I would do for my child, err on the side of caution. Okay, so persistent platelet dysfunction. Like I said, platelet counts, actually, if they normalize, but they can come down, because what happens is a virus will actually kind of inhibit the bone marrow from producing new platelets, so you can have an acute decrease. That's why sometimes I hear stories where a kid was doing fine, they get sick with a cold, and all of a sudden they have the petechiae, the spots all over, and that's what that's a reflection of. Rarely your child will need a transfusion for platelets, and we really try to minimize that, because what happens is, in most cases, your child can still make antibodies, and if you keep like knee-jerkingly transfusing platelets over time, your child will make antibodies to those platelets, and they can actually eventually become what we refer to as platelet resistant. And I just think there's that family here whose daughter had a heart transplant and has had a lot of problems, including bleeding, and she is now basically completely resistant to platelets, because every time they try to transfuse platelets, if she is at risk for bleeding, she eats them up because she's got antibodies to them. So we really try to be thoughtful. Yeah. Right, so I will come to that. So at times of risk, so while we're on the topic of the questions, what about dental surgery like wisdom teeth? Well, wisdom teeth can have pretty significant bleeding complications with Trousseau. So two things: don't do it out in the boonies, don't do it in Parker, do it at the children's or an adult hospital in Denver. So at times of risk for something like wisdom teeth extraction, what we recommend is at least have them on standby, meaning they are there ready to be transfused. And in some cases, and this is where I would defer to the judgment of your child's hematologist, they might opt in that case to go ahead and transfuse platelets at the time of surgery. And that's okay. That's very thoughtful, and that can literally be life-saving. but don't give platelets every time your kid has a tooth cleaned. So there are specific times where I do think the benefits outweigh the risks, but you only get your wisdom teeth out once, and so that shouldn't convert you from being platelet responsive to platelet resistant. Question?
Like in car accident, there might be internal suspected trauma, but not external.
Right, so the question is, what about a situation of blunt trauma where there might be internal bleeding? Again, I think it's a judgment call, but if there is significant clinical concern, like for rupture of the spleen, I think by all means, that can be a life-saving intervention. So that's got to be the judgment of the treating physicians. But again, if the circumstance suggests that there's significant internal bleeding, I think by all means, that's a life-saving intervention. Again, as opposed to something like, tooth cleaning. Go ahead, Jerry.
I was just gonna make a comment that, you can ask them, because Faith has had a lot of surgeries, and they always have them on standby, but we always ask that they do a function test prior to the surgery, so they know kind of going in and then you can make then that'll help you make the decision.
So the question is, how do you prepare? Well, I'm going to follow up on your point about platelet function testing. Just hang on to that thought, because there is no specific platelet function test just for Trousseau. So you can even have a normal platelet function test, but that doesn't mean you don't have risk of dysfunction. Go ahead.
In relation to Trousseau and the way that they have, or the way that they can spontaneously have bleeding complications, we're at a place now where we had to consider whether or not CPR is something that we should do with compressions. Have you had any incidences with any patients during a major complication or a crisis where they had more damage due to compressions than not?
Well, fortunately, I haven't had too many patients that need CPR, thank God. I can't think of any situation specifically of a child with Jacobson syndrome that received CPR where more harm than good. I mean, if you need CPR, it's like you'll deal with the bleeding problem later, like save the life. Right, so. Okay. And again, really be thoughtful about transfusion. So coming back now to Jeremy's point, diagnosing. So again, there's no specific test for Trousseau, which lends to the confusion because, someone, a primary care doctor might do a garden variety function test and say it comes back normal. It's just not the right test to perform. So keep that in mind. And the other thing is, some of you have probably been told that your child has von Willebrand's disease. Has anyone been told that? Yeah, a few. Well, guess what? Your child does not have von Willebrand's disease. It's a false positive just based on the way the test is done. So very unlikely that I'm going to give your child a third diagnosis. As Dr. Lambert, if you watched her talk sheet, and I'll show you in a sec, one of the ways that you can diagnose it is actually looking under the microscope at the appearance of the platelets. And I'll show you an example of that in a moment. So it's not a functional test, it's more like an anatomic description. And if you see those abnormal platelets, that clearly goes along with Trousseau. That's not a normal finding. The other thing that you have heard Dr. McKenna allude to is that the other bone marrow cell lines can be affected, namely red blood cells. So if you have low red blood cells, you're anemic. As you heard from Dr. Dom's talk, if the white blood cell count overall is decreased, that is very indicative and suggestive of some kind of immune deficiency that requires further testing. This is also a really important point if this is more kind of in a newborn scenario, so after the fact for most of you, but if anyone ever suggests doing a bone marrow biopsy, which is not the most pleasant procedure for those of you whose children have had one, most of the time it's not needed because we already know what's going on once you have the Jacobson syndrome diagnosis. Go ahead.
Related, we just moved from pediatric to adult doctor.
Good luck.
Yeah, this adult doctor is kind of long story, but
We're the tissues. I'll be right there with you.
has the multiple blood draws, which C does not tolerate at all. to test if DDAVP really works. And we're like, the protocol is the protocol. Like, they just want it, she thinks it looks like 1 milligram, she thinks she might have both. Both Trousseau and 1 milligrams were like, no, just please look at the protocol. So my question is, our former pediatrician signed the protocol, was like, trust you, trust what you're saying. But now we have nobody to sign the adult protocol, because the doctor is coming back wanting to do more tests. So can her adult pediatric doctor sign it, and then, do you know what I mean? Like, maybe that's a question for the attorney, but
Well,
we just need somebody to sign it, it's not a pediatrician. You know what I mean?
I would actually go to Dr. Lambert.
Okay,
She's, you know, we had Dr. Geddes years ago, but she moved away and was kind of falling out of the scene, but it sounds like, Lindsay, correct me if I'm wrong, but I think Dr. Lambert is really kind of offered to kind of step up to advocate. And I think that's what you need, is someone to advocate for your now adult age. Yeah. That's crazy. I mean, unless there's something else going on, but, you know, taking it face value for what you're saying,
that's fantastic, but like,
you don't have to reinvent the wheel here. Yeah,
okay,
now, you know, I'm not aware of ever this happening, but if, let's say there was truly a suspicion for leukemia, okay, that's when you do a bone marrow biopsy. Touch wood, I am not aware of a single case of leukemia in anybody in Jacobson syndrome, so, make sense? All right, and again, just to reiterate, in most cases, a bone marrow biopsy is not needed. And this is what I'm referring to. This is an electron microscopic image of a normal platelet, and I don't know how well you can see these little black circles. Those are what's called the alpha granules. Those are little storage compartments within the platelet cell that contain factors that mediate normally clotting, okay? And what happens in Paris Trousseau is these little circular bodies actually coalesce to form this giant alpha granule. And normally that alpha granule is not able to release its contents to help promote clotting. And so that is almost diagnostic, as you'll, if you hear Dr. Lambert's talk, that's almost diagnostic. It's not a functional test, it's just a visual, you know, electron microscopic image that if you see that, that's very, very abnormal. Now, what's interesting is under most physiologic situations, these giant granules just sit there and they're not able to release their contents to mediate clotting. I've seen a couple abnormal situations, namely cardiopulmonary bypass, where there's this kind of physiologic stress that actually can induce probably these giant granules now to suddenly release all these contents that have been building up. And now all of a sudden you go from a risk of bleeding to a risk of clotting, thrombosis. And I've literally seen that in the operating. That's highly unusual, but it has been known to occur. But anyway, to the point, to help make the diagnosis, you can just take a normal blood sample and put it under the specific technique of electron microscopy to get this kind of image. And as far as I know, if you see that, that's more confirmation in case there's any doubt. And you can even see it on, oh, go ahead.
from the dense granule deficiency, but no alpha granule abnormality. That's why they're trying to tell me she doesn't have it, but she has some.
Well, so the question is, I think you said that there's an absence of the little granules, but no big granules, right?
That's no alpha granule abnormality.
I would probably defer that one to Dr. Lambert. So some subtle observation on the electron microscopy that suggests no alpha granules, but no big ones either. So I don't know what that means. Maybe they just didn't look at enough. You know, for every cell where you are missing the alpha granules, not every cell may have the big one, maybe. I'm not sure. But it sounds like it's still in the spectrum of Paris Trousseau. That's what I would conclude. And then again, like I was saying, just a normal blood draw, a normal CBC, these little cells, the little halos are mature red blood cells. This is a very abnormal, very large platelet, almost the size of a red blood cell. Normally, it's just a little speck, more like what you see here. So, and you do have a mix of some normal and some abnormal. So you have to look enough to see enough of a representation of what's going on to make the diagnosis sometimes. Okay, so some kind of hands-on recommendations. Again, kind of obvious, once you get the diagnosis of Jacobson syndrome, we strongly recommend to get a baseline evaluation from a pediatric hematologist who specializes in platelet disorders. Like I said, I know I'm sounding repetitive. In general, unless there are actual bleeding situations going on or high-risk situations for bleeding, transfusions should not be needed. And I've already talked about why it's so important to limit the number of transfusions. And lastly, this gets also quite overlooked, and that is there are many common, even over-the-counter medications that inhibit platelet function. Arguably, some people knowingly have been giving their children medications like ibuprofen, fortunately so far without any deleterious consequences, but in general, we recommend avoiding any kind of medication that inhibits platelet function, like ibuprofen, hang on to that, like aspirin. And if you're not sure, ask your pharmacist, or just, you can probably Google. Of course, every medication has every side effect, but if you just, whatever medicine you're concerned about, just Google and look for side effects of affecting platelet dysfunction. Yeah, Beth. Aspirin, sorry. So aspirin is another inhibitor of platelet function, thank you, that you want to avoid. Back there, go ahead, and then we'll get back to you. Yeah. Yeah.
And we have been high dose ibuprofen. And so is there any other option if you have pain?
Well, yeah, there's something called, so the question is for their child who has, sounds like neuropathy, they've been using high dose ibuprofen, and it sounds like luckily getting away with it, but not ideal. You know, there are other medications that are used to treat neurologic pain, like gabapentin. However, that does have some side effects, like causing drowsiness, but there are other alternatives, so you can definitely talk to your neurologist about that. Jeremy.
Get your opinion. So we were told at a very young age, we went to the ER at one point to tell the hospital or whoever that you have an allergy to ibuprofen and aspirin, because they treat that different than if you just say they have a bleeding disorder and they might brush you off.
I wouldn't use the word allergy, because allergy refers to a specific mechanism. And they might, you know, it's like in this case, it's probably some antibody response, in which case they might treat prophylactically at the time of treatment with whatever medication, with a steroid. Well, a steroid is not going to alleviate the risk. So I would not use the word allergy. I would just call it what it is. They have platelet dysfunction. Okay. Yeah.
Like Amicar usage for like cautionary, you know, before surgery and stuff like that, or is that fine?
Yeah, so the question is there a limit to how frequently you can use medications like Amicar, which help to inhibit bleeding? As far as I know, there isn't, but I'm not the expert on that. I mean, usually Amicar or the IV form is used basically in a situation of acute bleeding or risk for acute bleeding, which means it's only rarely used. I'm not aware of any consequences of, you know, long-term side effects from the use of that class of drugs, but I would definitely run that by a pediatric hematologist. Yeah.
As for on Amicar 2 times a day, and it's been many years now.
So maybe that helps to answer your question.
So still can't like get her above 100, and she's always bruised, so he just keeps it like prophylactic stuff for her.
Well, I would hope that anyone who's prescribing Amicar for persistent recurrent bruising is more savvy than I am to know about long-term consequences. So that might be the answer. Okay. Yeah, so non-steroidal anti-inflammatories, aspirin, ibuprofen, those classes of drugs, and probably others.
I do remember Dr. Lambert saying that fish oil can make the platelets slippery. Cause I remember thinking that, 'cause my kids were on fish oil, I'm like, what?
Is slippery good or bad?
That's bad.
Probably bad as in like non-functional. So, you know, I would
Yeah.
say there are probably different preparations of fish oil. It's probably not regulated by the FDA, so you probably need to really sort out what's in that particular preparation. I would have no reason to dispute that, but you probably really need to know what's in there. Okay, yeah, I mean, this is after the fact for you guys, but like I mentioned, if you have a prenatal diagnosis of Jacobson syndrome, we recommend an elective C-section to avoid head trauma and the risk for bleeding in the brain. All right, so management during times of risk, we're already kind of addressing that. So we already emphasized for any kind of elective procedure that puts your child at increased risk for bleeding, you guys really have to be the advocate. You guys really have to form a team to make sure that your treating physician, let's say, whether it's wisdom teeth extraction, dental surgeon, or some of, craniosynostosis surgery, has to be in contact with the hematologist who hopefully knows about Paris Trousseau. Yeah.
If, as in Harlan's case, she's had 3 of the
Yeah.
heart surgeries and never had bleeding issues. Can that change?
So that's an interesting point. So when you have open heart surgery, normally when you go on the heart lung machine, you are transfused platelets as part of the normal protocol. So, that's going to mask, that's going to take care of the risk problem. So that does not mean they don't have a bleeding risk, but it's already addressed as part of the normal protocol for cardiopulmonary bypass.
Since then be the same, like catheterizations and stuff.
Well, that's different. So cardiac catheterization, you do not need platelets normally. We've had a few in San Diego. What I've recommended to my interventional cath colleagues is just have platelets on standby, but don't necessarily transfuse. And the few times when we've had a Jacobson syndrome patient have a cardiac catheterization, they never needed it. So.
But that's why we were told years ago by the hematologist when she first went for the testing that she has a marker for Paris Trousseau, don't worry about it because she doesn't have the bleeding disorder. She obviously went through 3 surgeries.
Yeah, but my point is that's a false sense of confidence.
Exactly,
Right.
but that's
Yeah.
why we had false sense
Yeah,
of
of course.
confidence for the last 10 years.
Yeah, well, that's why we have these talks and these meetings, because it's,
And then we had nosebleeds in
Yeah.
college where she went to,
The ER last.
but
Well-
we didn't know what to tell, we didn't know what to tell them.
well, now you know, right? You're armed with the knowledge and, unfortunately, most people don't know about the medical issues of a syndrome that occurs 1 in 50,000 births. So it's on you guys. Yeah.
Also, heart surgery, so they didn't know, the hematology. They were so upset, we didn't yet know that she had low platelets.
This was at Boston Children's, you said, oh, God.
Yeah. And so there was some confusion, there was no release in Friday. She was and then that's the reason why we've been so confused. I think I've asked so many questions over the years.
Well, in our case report, 1 of the 6 was a heart patient at Boston Children's that was also put on Coumadin. So basically your hip was put on Coumadin in addition to having a platelet problem. So now you've knocked out both clotting systems and that child had a fatal brain hemorrhage. Anyway, so this is why it's on you guys, But anyway, again, just to reiterate the point, you can have a false sense of security if your child has open heart surgery and doesn't have bleeding problems. I will say that we have had at least 1 or 2 kids in San Diego that have had heart surgery. They did fine with the heart surgery, but when I talked to the surgeon, even in the OR, they were having more bleeding intraoperatively than what you might expect. And in that case, they might need additional platelet transfusions in the immediate postoperative course. So again, it's all, we published a paper several years ago now on treatment, surgery for hypoplastic left heart syndrome and Jacobson syndrome. And these are those details that are so critical, which, make a difference, which historically some surgeons would like push back and say, no, I'll never do an operation on that. You can, but these are the details that you have to know. Go ahead, Jerry.
So you'd be able to tell us better, but so our problem, they were so obsessed with the platelets that it was an electrolyte imbalance. I don't remember if it was potassium or calcium that helps aid clotting, but there's electrolytes that are involved as well.
Probably calcium, so,
Yeah, so,
vitamin K, of course.
yeah, so I mean, and this was back in '04, you know, so I just, they were so focused on the platelet disorder that the first thing the cardiac ICU, she ordered, she was like, I don't care that you don't have it, give me that test. And she hung a bag and her bleeding just went to normal, just like that.
Yeah, I'd have to, maybe you can research that a little more, but,
Yeah.
you know, maybe they give her vitamin K, I'm not sure. That's what I have. Yeah,
When she was younger, but then when she was in fourth grade, she got a tumor and it was benign, but the doctor did say afterwards, and they did, at this point, they did have platelets standing by, because we did at that point know that she had Trousseau. And, they had platelets standing by. They said they didn't use platelets, but she did have some abnormal bleeding in the putter. So they did plan and everything, but she didn't have platelets, but she did have that.
So she did get worse when she was younger.
Worse, and she has never actually had, she, for a little while, when she was like in young age, she had, kind of normal, like 150, but it's never been normal. She's in her 40s.
well, and again, I think the clinical course over time can be variable in terms of counts, not to mention the persistent dysfunction. You know, that's why I say thoughtfully err on the side of caution. Yeah,
Question or comment maybe, Bo, about menstruation, helps the growth, orals. It was a major question I was hearing everybody involved in, I was in that situation ahead of us. Last conference, and we landed on a state of trans and acid.
Right.
Patient. The question part about it is, this last cycle, she did pass a lot. It's insignificant, kind of made her nervous. I mean, I guess the good news is she's clotting, but I don't know if there was any, anything we should raise about that or investigate further.
well, there are probably people in this room that know more about it than I do. I would work with like an adolescent medicine doctor or a gynecologist who specializes at least in adolescent care to help manage regulation of the menstrual cycle. Sometimes it's completely shutting it down with oral contraceptive versus tranexamic acid. That's not what I'm familiar with specifically being used for treating menstrual cycle. Okay, well, that might be warranted. Yeah,
I just had a plan.
right.
I didn't have a plan. Yeah. For the contraception, so literally take it out, put new one in, so she can have her. Yeah.
Go ahead.
I was just gonna say something similar. We saw a pediatric OBGYN.
Yeah, pediatric gynecologist, you're right.
And also had the implant, which has worked beautifully for us.
Yeah. So there are very effective ways to manage it for those of you that are sort of panicking.
Typically. Pediatric hematologist,
Yeah.
but maybe it's helpful to have.
Yeah, I don't know if it's a good idea to be treating with tranexamic acid regularly, kind of like what we talked about. But it seems like there's a pretty good track record of OCPs to regulate the cycle. Yeah.
While back, some of the conversations about the, contraceptive use, we were worried about some of the hormones and, how it was affecting some of the vessels in the brain. Is the medication in the implant anywhere on that spectrum?
So the question is, I think, can oral contraceptives promote actually clot formation? That's the concern. That's something you have to take up with the treating person, but in general, I know that they have lowered the doses to try to minimize that risk for clots. So,
The medication used in the implants, is it on that same type of spectrum?
well, I think it's some let me wave my white flag here, but it's some combination, I think, of estrogen and progesterone. And the devil is in the details in terms of the dosing, in terms of risk for clot formation, and that's something we really need to take up with the people that prescribe that.
Thank you.
Where are we? Okay, so let's see. Have platelets for transfusion on standby, you know, times at risk. Some of your kids have had craniosynostosis surgery, so repair of the skull, which is a very high-risk bleeding procedure. I learned early on of a child that died or almost died in the operating room. They had to abort the case because they didn't know about the bleeding. You can imagine. Wisdom teeth extraction, at least I think have them on standby clear. Cody Gaines, who's probably 30 years old now in Florida, I remember years ago, had persistent nosebleeds, and at one point it was so severe, he was actually admitted to the pediatric ICU because he had so much blood loss just from the nosebleeds. So, you know, it's unpredictable. And of course, present that bleeding protocol. We talked a little bit about brain aneurysms. We learned in a relatively short period of time that we had gone years before I knew of another one. And then all of a sudden, in a few years, I learned of like 6 cases, multifactorial in terms of cause. But if you can imagine, whatever the cause, let's say high blood pressure, including in the brain blood vessels combined with a bleeding disorder, can be a pretty bad combination. And so, we recommend at some point at least a baseline brain MRA to specifically image the blood vessels in the brain, because 1 or 2 of the cases that we described did have evidence of a brain aneurysm. And actually, if you find that ahead of time, these days, there are interventional procedures that neuroradiologists can do to, you know, treat an aneurysm in the brain, hopefully to prevent something catastrophic from happening. Let's see, so we just kind of talked about that. Usually it's not going to happen in early childhood unless it's like at the time of birth from a traumatic delivery. If your child is getting something else done that needs anesthesia, I would suggest that you piggyback on a brain MRA. It's a pretty quick procedure, and then you're not having any risk.
Is it too late if they're 27?
I would, if she ever had one, I would do it. Yeah.
Do it.
I recommend that for everybody. It's never too late. And at least, you know, if you get it done now, you'll have a baseline. And since we initially made this recommendation, I know of a couple of cases where one was identified. It doesn't mean they're going to drop it tomorrow, but it does mean a little more careful surveillance and really be aggressive about monitoring blood pressure, right? And there's a heart defect called coarctation. It's like a kink in the aorta, so everything above it is very high in pressure. So again, you know, high blood pressure, a brain aneurysm, and a bleeding disorders could be a lethal combination. Okay, that's it. Yeah, I'm done. So I knew that most of this would end up being question and answers. So
We can keep going with questions and answers, but if you have kids, the workers need their little break before we have our lunch and learn, but we can keep that to questions.
yeah,
Just to add, I think the veterans all know it, but the new parents, we actually at the time Brad chopped with Dr. Lambert, we had like a year or 2, but
perfect.
a very minor, right, like very minor surgery. But even in their internal system, they didn't connect the fact they didn't like
They did not.
They've not, until the day of the surgery, we said, great, platelets are here, right? And he said, what are you talking about? And so we had to cancel the surgery. It's just annoying. So my advice would be just like, if you're gonna schedule anything, just minor, just confirm a couple weeks in advance, like, hey, just make sure you got the platelets, right? You got that protocol, because even in that system with her, they just didn't click on the file.
So because
She didn't know.
these days in medicine, people work in silos. That's the problem.
It was just like annoying, we just had to reschedule it, but luckily she'd go into surgery.
So my unofficial recommendation, be a pain in the ass. Just bug them until they like, yes, we know, thank you, okay, good, mission accomplished. You know.
One other thing.
Sorry for the.
We've had
sorry.
issues with, we never had it with pediatric care, but now that we've moved to adult care in the hospital, they always want to put him blood thinners, because he's gonna be in a hospital. Every single time, I'm like, you can't get in there, have you read his chart? Like, so just like be aware when you move to adult care that it sometimes.
It's like you're starting over from scratch.
Sometimes that's like protocol, if you're gonna be in the hospital for a while,
Well, and it is, and that's a big problem, to reduce the risk of pulmonary embolism, but you have to weigh that.
Right, and so I just
Yes.
have to, every time now he goes to the hospital, I have to check and like, do not give him blood thinners. You can put those little things on his legs if you want, I don't
Yeah.
care, don't give him blood thinners.
What are the little things on?
Oh, you know, like the little thing.
Pressure.
Pressure stockings, yeah.
But, you know,
And turning him and making sure he doesn't get, bed sores. What other questions? Yep,
I was just gonna share one story again for the, your families. And Dr. Paul, you get involved in this, but I probably don't remember it, but when Sydney was probably second or third grade, she did have to have a dental procedure, and it was wonderful because they scheduled it at our children's hospital, they agreed to do a longer sedation. And everything went well until we got the bill from the insurance company that they said they wouldn't cover it because it wasn't medically necessary. So we should.
which procedure was that?
The dental procedure at Children's Mercy Hospital, they weren't gonna cover the operating room cost, and I remember
Ah.
all that meant for us. Wonderful. Try to advocate with the chief medical officer at that to cover the procedure. Just telling you that because if you're having a procedure done, like a dental procedure, check, make sure that they have gotten it reauthorized, because, I mean, we all know health insurance is a huge pain. But it's just like, it would have been much less stressful if we had worked on this before we actually had the surgery versus the post-surgery when we got the bill for $27,000. And we were able to mercy, they were wonderful, they ended up, that never did cover it, they ended up, forgiving it. Which was great, they didn't have to do that.
Well, that's where insurance, but again,
Yeah.
to your point, be proactive.